Just by way of introduction, most of you will know Selina, who is my consultant colleague at the Queen Elizabeth and previously did a PhD in mesothelioma, and since that time has developed her own research portfolio which includes EXTRA-Meso, which she'll tell you all about.
Thanks. EXTRA-Meso was only funded by Meso UK about 4 or 5 weeks ago. So we're kind of still early in the process of study setup and study design, so any comments are more than welcome on this. So a bit of a background rationale of why we wanted to maybe do an exercise study in Meso. Respect Meso, most of you will know, is a randomised controlled trial looking at early palliative care involvement in patients with mesothelioma. So all the patients in this study were performance status 0 to 1, so they were pretty fit. Over half of them in the study were planned for chemotherapy. And you can see that the patients had a relatively high symptom burden in that study despite being of good performance status. We've already heard a lot of issues with pain earlier on with Barry's talk, but also breathlessness and fatigue are prevalent. The table below describes almost 500 patients where quality of life data was looked at across 2 multi-centre studies where patients were being randomised to chemotherapy. And you can see that the prevalence of symptoms at baseline were very high, particularly fatigue, breathlessness, anorexia and pain. And 92% of patients among this 500 reported 3 or more symptoms. So our patients have a high symptom burden. We also know that emotional symptoms are very prevalent in patients with mesothelioma as well. So this is a summary of a survey conducted by the British Lung Foundation in 83 patients with mesothelioma. And you can see that rates of anxiety and depression and fear, anger and isolation were all common in patients and their carers with mesothelioma. Looking at overall healthcare related quality of life, on the left is a table of a Japanese cohort study of patients with mesothelioma. So this is all comers, all performance status, all stage, and the global quality of life. So the lower your score, the worse your quality of life, you can see is relatively low. The graph on the other side was looking at quality of life in patients in a randomised controlled trial of chemotherapy. And the mesothelioma patients are the black line. So as I said, for the role function, social function, that you can see patients with mesothelioma had a poorer quality of life in comparison to patients with lung cancer, for example, and higher levels of fatigue and appetite loss and breathlessness. We know from that Anna Novak study that patients who had a poorer quality of life also had a poorer overall survival, and that was across a number of factors in the quality of life scoring, and it was an independent predictor for overall survival in those studies. So we know patients have a poor quality of life, got a high symptom burden, high levels of anxiety and depression. We also all know of this phenomenon called quite a complex phenomenon. It's multifactorial. It essentially describes loss of muscle mass with or without loss of fat, which is not easily remedied by nutritional input. And we know, although it's complex, we know that there is an interplay between inflammation, cancer and cachexia, and it almost becomes a bit of a vicious cycle. We know that pro-inflammatory cytokines such as TNF-alpha, interleukins 1 and 6 and interferon gamma are upregulated in cancer, and downstream transcription regulations show that these upregulated cytokines result in a lot of catabolic pathways being activated. But overall, the pathophysiology is still poorly understood. We know that malnutrition and pre-sarcopenia are high in mesothelioma. That's the Australians looked at it, and over half of patients were pre-sarcopenic at baseline diagnosis. We know from other solid tumours such as melanoma and lung cancer that if you are sarcopenic, you have a poorer progression-free survival and a poorer overall survival. And Andrew Kidd looked at sarcopenia, so thoracic sarcopenia and sarcopenia in general in patients who are getting chemo. Over 50% of patients were sarcopenic, either pre-chemo or became sarcopenic during treatment. And those in particular that became sarcopenic during treatment did significantly worse than those who did not. Moving on to exercise, we think it's a rational thing to try in patients with mesothelioma and other cancers. We know it improves cardiorespiratory and functional fitness in lung cancer, for example. It improves your quality of life and reduces anxiety. Also reduces post-op complications in those going for surgery with lung cancer. And there is some evidence that it may improve muscle mass, muscle strength and physical performance in patients who are already sarcopenic. And it may break that vicious cycle I showed you earlier of cancer, inflammation and cachexia. So that was really the background rationale of why we wanted to look at exercise in mesothelioma patients. So EXTRA-Meso, really what we're planning to look at hopefully in future phase 3 trials is really what role it has, a tailored exercise and nutrition support programme in patients with mesothelioma using patient-related outcome measures, so things like quality of life and treatment tolerance. What I'm talking about today is really the design of a feasibility study. So it's where the primary objective of this study is to determine whether or not it's feasible to recruit a mesothelioma population to an exercise study. And through that, we'll determine barriers to study recruitment and retention and the safety and tolerability of the exercise itself and the quality of life to be asking them to do. So it's going to be a randomised feasibility study. We're going to be recruiting from here in Glasgow and also in Manchester, who many of you will know already have a prehab for cancer, well-established exercise programme for patients with lung cancer, but not for mesothelioma. The eligibility criteria are going to be reasonably straightforward. So it's going to be a diagnosis of meso as determined by a mesothelioma MDT. Performance status is going to be 0 to 2. They're not going to be overly frail and they're going to be able to give informed consent. And either the physio or the physician will need to believe that they're going to be able to participate in an exercise programme. The design of it, again, is going to be fairly straightforward. All patients will go and look at things like their MUST score, their functional fitness, and some quality of life scoring. They'll all get randomised 1-to-1 to either standard care, where they undergo follow-up as normal within our clinics, or they'll get randomised to an exercise intervention, and we'll get followed up at 16 weeks, again, with quality of life questionnaires and functional fitness assessments at that stage. So the baseline assessments, we're going to be looking at basic patient demographics, so age, disease stage, histological subtype. We'll also be looking at their body weight, their BMI and their MUST score. So for those that don't know, the MUST score is a simple screening tool for malnutrition. And all patients, no matter what arm they get randomised to, will be referred to a dietitian if they meet criteria based on these 3 factors. We'll also look at their functional fitness. So that will be how many times can they sit down and stand up in 30 seconds from a chair to standing, what is their hand grip strength like, and how far can they walk in 6 minutes, which are all really kind of quite standard measures of functional fitness. We'll then also ask them to complete validated quality of life questionnaires. So these 3 in particular are well validated within a cancer community. And we'll look at a sarcopenia screening tool and also measure skeletal muscle mass area. So that's as a determinant of sarcopenia. So these are images from one of Andrew's studies, CT image at the level of the L3 lumbar vertebrae. And essentially you put it through a programming software to detect Hounsfield units that are that match muscle mass. And then you manually delineate what is the intercavity, so taking away the sort of red that you can see, for example, of the liver and the spleen and the kidney. And then once you've taken that away, you're left with the muscle mass area. And we know that you can perform this at a thoracic vertebral level as well as the lumbar vertebral level from Andrew's work. So we'll be able to look at that on the routine clinical CTs that patients get at diagnosis and during follow-up if they are getting treatment. The exercise intervention itself will be based on the Prehab for Cancer programme that they have in Manchester. Essentially, patients will get assessed by a physio or a level 4 qualified exercise professional who's had specific cancer training. They get prescribed their own individualised exercise programme, and it's based on their fitness, their ability, the availability of exercise equipment. So the great thing in Manchester for Prehab for Cancer that unfortunately we don't have here is that if you're in Prehab for Cancer, you get a free local gym membership. So patients can use their local gym, and really it means that even after the 12-week program, they can go on and keep going with that kind of well-being and exercise lifestyle. So we're obviously not going to have that available in Glasgow, but the ability of exercise equipment will be taken into account for their programme. Also taking into account patient injuries and whether or not they're confident with exercise in general. It'll be 3 weekly sessions over a course of 12 weeks, and it'll be a hybrid model of probably one face-to-face assessment with the exercise professional or physio per week, and 2 self-directed sessions that they can either do in their gym or at home. It includes cardiovascular and resistance training, and it's progressive in terms of intensity, so how hard the patient needs to work, and also the volume of the reps if it's resistance training, or the duration of the exercise if it's cardiovascular. The resistance training will target the main large muscle groups, so a pull day, a push day, legs, well not days, sorry, pull, push and legs exercises. And a patient will have a simple diary just to record whether or not they can complete these exercises or whether they did complete the exercises and what they thought of them. This is just a screen grab of YouTube. So Prehab for Cancer, they've got their own YouTube page where you can see if patients are exercising from home. There's some really easy to follow programs that they can do from home as long as they've got access, I guess, to a computer or a smartphone. We'll be conducting qualitative interviews with a number of patients, so a group of 5 patients who declined to take part, and that's really to assess barriers to study recruitment. And then between 10 to 20 study participants and their carers, hopefully including some patients who drop out during the course of the study. And that's really to, again, evaluate the exercise programme and evaluate barriers to study retention. This is, I'm not going to try and pretend that I understand qualitative analysis, someone else is going to do it, but it's basically based on this kind of 5-step framework analysis that's validated for analysing audio transcriptions from patient interviews, and essentially you'll get a map of common themes that come out from all of the interviews that you get. It's a feasibility study, so we need to have metrics as to whether or not we proceed with the future phase 3 or not. And our feasibility study metrics are really going to be looking at recruitment, first off, and intervention adherence, so adherence with the exercise programme across the 12 weeks. And you can see there that we'll have a red light, which means that we wouldn't proceed to the next study, an amber light, which means you're probably going to need to modify your study protocol to continue, or a green light, which means you can continue or only very minor changes to the protocol are going to be required. Always, it's never good to display a Gantt chart where you're already several months behind, but I'm taking no blame for this one, because actually originally we thought we would find out about the Meso UK grant in December last year, and as I said, we only found out 4 weeks ago. So essentially a few months of study set up and kind of protocol finalisation and ethics, and then we're going to recruit over a period of 12 months. The qualitative interviews will happen during that 12-month recruitment period, and then we'll follow up patients up to the 16-week mark, and then hopefully have data kind of into the second half of next year. And that's really it.
That's really exciting. It was kind of 2 questions. Just one simple one is, are you going to ask anything about the people in the control arm if they increase their exercise? Because obviously if they've been introduced to the idea, they might then go on and do a bit more.
Yeah, it's a good idea. So all patients, whether or not you're in the standard of care arm or the intervention arm, will get follow-up at 16 weeks to look at their quality of life, to do their 6-minute walk and functional fitness. So it's a good idea to also ask if they've changed their activity in the preceding time on their own. It's a good idea.
And then the only other thing was, you may have already said it and I missed it, is when are you going to ask them? Because obviously if it's like you're diagnosed with meso, then they've obviously got a lot going through their head. Is there a time point where they wouldn't be eligible to go into it?
So I've been thinking quite a lot about this recently, just from reflecting on the difficulties that we've had in recruiting patients to assess meso, which is just an observational study where we're trying to ask patients at diagnosis, will you enter this observational study, we'll be recording data, if you get admitted we'll record this. And I thought that would be dead easy to recruit to, they don't need to do anything. But actually it's been much more difficult because of that. They're getting hit with a lot of information at diagnosis. They're coming to terms with diagnosis and they just don't want to think about anything else. So I think ideally you would say you would introduce it at diagnosis, but I just don't think that's going to be possible. I'm hoping that a lot of our patients now are meeting with oncology teams to have a chat about that, and it almost ties in with where we do prehab now for kind of lung cancer, for example. It's often introduced at that just before you're getting referred for treatment stage, so it might be then. There will need to be a window in terms of time from diagnosis, but I don't think I'm going to be particularly stringent with the window. I think some of these things are the reason to do a feasibility study in the first place, so that when you get to the phase 3, you've got all these questions ironed out.
If they can't get a gym membership, where are they going to do this exercise?
Yeah, so there's some basic equipment that we've got, like kind of resistance bands and things like that, and I'm looking at Noelle because the original plan was to use the prehab gym that is in the Beats, and they've got a kind of prehab program, but I think that's starting to fall apart a little bit. So the face-to-face session was designed to be in the prehab gym at the Beats Inn. And then if they don't have a gym membership, then they can do the at-home exercises, which there will be a prescription. It'll be really simple, like, sit up and stand down from the chair, attach a resistance band around a door, or, kind of following those YouTube videos. So there's, like, I can't even remember how many videos of this there were, but there was loads of different cardio exercises. It was like stepping up and down off a step, going for a walk, going for a faster walk, things like that. So I think there's a lot of home exercises that are going to be possible. I guess if they're super fit.
The gym's involved into it, because that's another trip to the hospital, isn't it, for patients already? Yeah, no,
absolutely. So I think that the difficulty is that the prehab for cancer came with a several £1 million funding, which allowed them to go into the gyms and get gym memberships for all their participants. And I dare say I don't have the big shoes to apply for several £1 million of funding just yet. I know.
This is just a thought on bypassing that several £1 million. I think within Glasgow City there is a mechanism by which GPs can do GP referral to Glasgow Life, where patients get free gym membership if they are referred by their GP for medical reasons. So I just wonder whether it's worth exploring that.
Yeah, it's a good point. Because there's that for Glasgow Weight Management Service type.
No, I think they have a kind of a better access than that you can get GP referral, which enables you to get free access to gyms, and you might be able to do some sort of wriggle around the rules on that one to see if it's feasible.
It would be amazing if we could.
I mean, it's the Manchester kind of experience, when you talk to those guys who did it in lung for the prehab, which is very successful, is that the devil was in the detail of the exercise prescription, and even the delivery of it. So I remember them reflecting on some gyms that were on board. They had PT who was kind of thought they were more than a PT and they were going to do some sort of cancer, they're a bit holistic, try this random, herbal X, Y, and so it's kind of, I think it's brilliant, and I think it could definitely support patients through therapy and reduce that attrition that maybe that accumulates. But I think the feasibility is the right way to go, isn't it, in terms of trying to understand how you deliver it and what the exercise prescription looks like. And
I think the exercise prescription itself has to be, like, the thought that goes behind it is really detailed, and like when you look at how they prescribe it, and in terms of making sure that the potency goes up or the intensity of exercise goes up as you go along. But obviously at the end of the day you're giving it to a patient, so whatever you prescribe is going to need to be really simple, not intimidating, that they feel that they're going to be able to do it and it is achievable. So I think that will be the kind of crux of it being complex in the background, but once it gets to user, quite simple.
What do the advocates or the nursing guys think? What would you think about kind of approaching a patient with that? When there are some, I think there are some in my head that think, oh, that would work, and then there were some you definitely wouldn't, but I'm not sure it's the sort of thing that would work. There's probably as a group that would take it on, but there's certainly a large number of patients that would find it quite intimidating. Maybe not for them, don't know.
Yeah, I think it's about the way you introduce it. If it's an opt out rather than an opt in, that this is what we do and this is why we do it. This is part of your care.
Your care at the moment, to be involved in this trial and see how we can improve your fitness, because they're low stage, they're coming now and they are quite relatively fit, but if we can improve that a wee bit with some extra exercise support, maybe some extra, the other part of it that I think about though is, are we going to give them dietitian support? And I think you did say it, but because you're making them increase their exercise, so are they going to increase what they're eating and drinking and change that?
So I guess it's something that hadn't thought about in terms of during the programme, because certainly at baseline, if you have a high muscle score, if you've lost 10% body weight, the kind of low BMI, usually you'll get referred to dietitian. But it's a good point of having a interim assessment might be useful.
I also think cost of living with dietary changes at the moment would be something that might be good to get just as a side of it, not something we look at, but something we should maybe recognise for the patients that are being involved in the trial. If we're then changing their diet, do they then need extra? Definitely at the moment. But that's something we think of as a clinical team rather than
no, it's totally
trial.
Relevant. It's totally relevant,
And obviously the CT measures of sarcopenia could identify patients who are more likely to, who've got a higher risk of death. You're not planning to recruit only sarcopenic patients, are you? Or are you going to think about?
So it's not part of the eligibility criteria of being sarcopenic or not. I think what Andy showed from his data was that so many of them are sarcopenic that we're going to certainly get a lot of sarcopenic patients in it. And if they're not sarcopenic at the beginning, if they're getting chemotherapy or immunotherapy, then chances are a good proportion of them are going to become sarcopenic. So obviously this feasibility is not going to be powered to detect changes in patients who exercise versus not in sarcopenia, and I doubt that will be the phase 3 primary objective either, but we will be looking at CT scans in everyone in the study regardless of if they're standard of care or exercise to look for sarcopenia using that kind of image J, like the red scan.
So sarcopenia is low muscle. It's a low amount of skeletal muscle, so less than you'd expect.
I was
Just wondering as well, because there's currently national funding for prehab that is being run through all the Maggie centres in Scotland, have you linked into that in any way to see whether they might be able to offer any support?
No, simply because of the complexity of the exercise prescription. So Maggie's is amazing, but it covers all tumour types. And I think that's the difficulty, because you're getting a lot younger patients with colorectal cancer, for example, as opposed to patients who are going to be older. They're going to have a high symptom burden to begin with. So I might get desperate to the point, because I've just lost my physio back from, she was seconded and I thought I'd get her, but it looks like she's gone back into the wards. And I don't know if John McClay's already emailed you about that. But,
I've got an email about that one. I'm thinking about that.
Help us, please, Joelle.
On my to-do list. But I was just thinking, because Maggie's have both physio and dietitian support as part of their prehab, whether there was any way of kind of piggybacking on some of your requirements to what might be out there.
So they have the Move More programme, so possibly similar to what you're saying in the respect of it's all cancers, it's through treatment. From a support group point of view, I think introducing exercise is excellent, but again, I think it's similar to when you're introducing support groups to some individuals. You know, it's not for them, particularly if they're older and are not used to going to groups or sessions and things like that. It's a whole life change for them, so sometimes that's not appropriate for them, particularly with a mesothelioma diagnosis. So sometimes it's almost working on individuals. Having said that, and you've just missed her because she was here this morning, one of my clients was here this morning with her daughter, and she, from diagnosis, she has a personal trainer. She goes to circle dancing every week, and she is in that older age group. So again, it does come down to individuals, but also maybe some around education, perhaps, for people to understand the importance of exercise, how that can actually help with, and again, as I know, I'm not a medical person, but how it can support treatments. It can support, as you say, you can reduce muscle mass just because you're unable to move around so much during treatment. But actually, if you can include that, then that's going to obviously lessen the opportunity for that to happen. So there's a level of education. If people maybe understood a bit more why it might be good for them, why it might be actually helpful for them, I think they're more likely to be involved, because obviously people want to be as well as possible for as long as possible. Yeah.
And I guess one thing that we could look at is, for the standard care group, how many of them access Maggie's or Move More or the generic kind of group-based sessions, and seeing, hopefully, if we can capture some of them in the qualitative interview, if there's any differences. I mean, do they need an individualised, personalised prescription, or will the group sessions do it? It's certainly, a question that's worth considering. I think the prehab, with regards to the individual and how you introduce the concept of exercise, I think what depressingly, I think what the Prehab for Cancer team have said is that if the consultant that sees you, that you've been seeing at diagnosis, says to you, I think it's really important, then they're more likely to go with it than if it's introduced later. But it's one of those challenges, isn't it, of how much information is too much information all at once.
Yeah, and it's that bombarding. Certainly, again, it's just from my experience, and again, it's not everybody. But you're right, at consultation, when you're diagnosed, we talk about the rabbit in the headlight moment. It's like, I need time to digest this and understand this. Don't give me any more information. However, by the time they go to the oncologist, that's actually seen as a very positive experience, because it's like, right, we're going to talk about treatment, we're going to talk available. So maybe around that time scale is a better option. Again, it's only a suggestion.
Oh, no, absolutely. Thank you.
Okay.
That's been really helpful. Thank you.
Yeah, that's been really good. So we'll just wrap up. I mean, I just want to say thank you to you guys for coming and for staying on a sunny day. It's hope you've enjoyed it. It's been I've certainly enjoyed it. It's nice to see so many folk face to face that we see on Zoom calls or team calls. obviously, thank you to Anna and Elaine and Laura for the organisation. All went very smoothly. And thank you very much to our sponsors. So obviously we've got a variety of sponsors here, and I'm always anxious about listing them because I'll forget one. But you all know who you are, and I can see you all here, and you've got stands out there, and it's much appreciated, you guys coming and kind of giving your support. So we'll let you get away, and we'll reconvene next year, I think, for another Education Day. And I think there'll be a Patient and Carers Day at some point next year, which is a bit more patient focused, and we might recruit some of you to contribute to that. But, thank you very much for coming.